I think we're going to start with introductions today first. I guess I will start. I'm Janelle. I'm an endo patient myself. I actually had my surgery with Dr. Haverland just about 2 years ago, maybe.
Yep.
Yeah, 2 years ago this month, I think. Previously, I've worked just in the pelvic pain space. I still am right now, working for pelvic floor physical therapists. And I've just been advocating for women's health and endometriosis for the past like 5 years. And I'm really happy to be here today. I don't know if who wants to go next, if Liz, you want to go next.
Yeah, everybody's probably met me. I'm Liz. I'm the founder and patient advocate and president of Endo Forward Foundation.
And then Dr. Haverland.
Hi, everyone. Thank you for having me. This is such an honor. I am Dr. Rachel Haverland. I am an endometriosis surgeon in Dallas, and I have been here for about 3 years now.
Awesome. And then Yar.
I am Jari. I am the creative director and secretary for the Endo Forward Foundation, and I had my excision surgery done by Dr. Haverland. I can't even remember how long it's been. Like a year and a half-ish, give or take.
Yep.
Awesome. Thanks so much for that. I think today we're just gonna, kind of talk about some important topics that are important to patients and kind of get your take on them. And I wanted to start with just in general, like fertility preservation. For patients who are still wanting to get pregnant, but you go into a surgery and there is a lot of endo, maybe it's deep infiltrating endo or they have a frozen pelvis. How do you go about approaching fertility preservation? Like, can you preserve fertility? Like, what are the rates? What are the complications?
Yeah. So endometriosis and fertility it's a touchy subject because it hits so close to home. It's so important for so many women. There are some women that don't want to have children, and that's completely fine. I mean, women are much more than baby makers. We provide much more to this world, but there are a lot of women that do desire fertility. And as we know, endometriosis is the most common cause of what we call unexplained infertility. Ultimately, there's a cause, but if you don't go looking for it, you won't find it. And so a lot of times I see women who have, worked with their REIs, have done an extensive workup and rather been unsuccessful with, IVF, unable to get, appropriate number of embryos, or just, trying naturally, don't feel comfortable moving forward with more like extensive measures and just not being successful. With that endometriosis, being the most, common cause of unexplained infertility, I want everyone to hear that women with endometriosis can still get pregnant, because I certainly don't want them to ever feel like, you have to have surgery to get pregnant, or if you don't have surgery, it's never going to be successful for you, because that is absolutely not the case. I do have women who are able to get pregnant without surgery, or who have endometriosis and maybe don't even know it and have been able to get pregnant. So I want to put that out there first, because I certainly don't want to intimidate anyone or scare anyone into feeling like surgery is something that they have to do to be able to be successful in this arena. With that being said, most of my surgeries are, preserving fertility. Most of my women, or most of the patients that I have, are young women that do want children in the future, or at least want that option in the future. And that's actually what makes endometriosis excision surgery much more difficult. It is much easier to go in and just take everything out, get really wide margins, and take out the uterus, take out, whatever excess tissue you have. But that's really not the goal. And as we all know, the definition of endometriosis is that it's not in the uterus. Because if it was in the uterus, it wouldn't be endometriosis. These are ectopic cells that are, not in the uterus itself. And so remember that the hysterectomy portion of treating endometriosis is not accurate, because the endometriosis by definition is not in the uterus. But when it comes to fertility and those other aspects, it's really important to know the patient's goals, right? So if fertility is a goal, being very careful with the fallopian tubes. I mean, these are very delicate structures. They are sensitive. They are not hardy. You have to be very careful with them. In fact, I don't ever touch them. I remove tissue around them, but I do not grab the fallopian tube itself, because it is very delicate and you can damage it. And then the ovaries. making sure that when you're separating these ovaries, removing ovarian cysts, that you don't damage the ovarian stroma. So the stroma of the ovary is the outside of the ovary, that like white part that you see on pictures. That's actually where the eggs are formed, is on this outside, this stroma. And so it's very important to preserve the normal stroma. So only going in, removing the endometriosis, the cyst walls, if they have an endometrioma, but not damaging the normal tissue, because that is where, they will make their eggs going forward. And so you want to have as much normal stroma as you can, or as much of that normal ovarian structure as you can. And then, besides, being very careful with the fallopian tubes, preserving the ovarian stroma, just making sure the anatomy and the important structures to preserve the uterus. So that's mostly the vasculature to the uterus. And sometimes that's really hard, especially with deep endometriosis, because a lot of times the endometriosis, when you get to stage 3, stage 4, actually kind of envelops the blood supply to the uterus and makes it a lot more difficult. So this dissection is kind of tenuous to make sure that you remove all the abnormal tissue, but by not damaging the blood supply. But, most endometriosis surgeons, the people that do this all the time, feel very comfortable with that. And I would say probably 80% of my patients do desire this fertility sparing aspect. The only time that a hysterectomy is not necessarily warranted, but where it's advantageous, is if you have adenomyosis and you know that you don't want to have, future fertility. And so most of my patients meet this criteria for fertility sparing. I kind of went off on a tangent. I'm sorry.
No, you're good.
That was perfect.
Is there ever a time that, patient wants to preserve fertility, but maybe you can't fully dissect a cyst from the ovary without damaging it, or maybe you have to take an ovary?
Yeah, it does happen. I will say rarely. I am an ovary saver. People talk about, big guns. I'm like, big ovaries. You use those big ovaries. Ovaries are very important. They give you your natural estrogen and testosterone. They protect your bones. They protect your heart. We now know, we're learning more, that they have cognitive protection too. Women that have their ovaries removed early, we call that surgical menopause, have increased risk of early onset dementia and Alzheimer's. Now, remember, this doesn't mean you will. I'm not, damning you to these diagnoses, but it does increase your risk. And I think it just shows us how much we don't know. Ovaries are very important. These natural hormones give us a lot of benefit. And even though we try to add back hormones that under the microscope look the same, they just don't function as well. And so I try with everything that I have to find as much normal tissue as I can. I will say sometimes it does happen, and this is rare. A lot of times we're able to talk about this beforehand, though, with patients, all the what ifs. So what if I get in there and your fallopian tube is too damaged and I can't open it? Or what if we get in and, I can't find any normal ovarian stroma to save? Like, it is all just so damaged. What do you want me to do? Because at that point, it's also a quality of life issue. If we leave this ovary that's so damaged, you're likely going to continue to have pain on this side. And if I can't find ovarian stroma, it's also unlikely that it's functioning for you, or that it'll continue to, at least for fertility. It may produce a very small amount of hormones, but very unlikely it would be able to produce an egg that would have any, decent genetic quality. And so I always try to talk about all the what ifs at surgery, because during surgery, I can't wake you up and ask. And so I try to do it ahead of time. And that way we're sort of all on the same page. But unfortunately, it does happen sometime. With that being said, you can absolutely get pregnant with one fallopian tube and one ovary. Losing one fallopian tube actually doesn't decrease your fecundity. Fecundity is the definition of getting pregnant, like in a certain period of time. What's funny about that is it doesn't really make sense, but you can actually ovulate from one side and the other fallopian tube can pick it up. So every time you ovulate from the right side, it doesn't necessarily mean that right fallopian tube is going to pick up the egg. The body is, truly miraculous in these ways. And so it's important to know some of these statistics beforehand, so you don't go get too frustrated.
I never knew that. I've never heard that. That is
Isn't it cool?
Yeah.
I did fellowship with a doctor that was both REI trained, reproductive endocrinology, and then she was doing a fellowship in surgery. And she was brilliant, and she was always up to date. And she would give me these papers, and she was like, make sure you're telling your patients these things. Like, the fecundity doesn't change that's lost one fallopian tube, but the ovary, of course, it may decrease it slightly, but you could still, usually the other ovary kind of overtakes the hormone making, and you ovulate more or less from that ovary every month.
That's amazing.
Yeah.
Do you ever suggest, like, if a patient, you know, definitely wants to preserve fertility, wants to have the option to have a child, if, you know, on maybe imaging, you do see like a really big endometrioma, or you see that, you know, everything's kind of stuck together, do you ever recommend them going to see a fertility specialist before surgery to even maybe like try to retrieve eggs or freeze them?
Yes, I do. And I am lucky to work with a lot of really good reproductive doctors. Some of them really understand, you know, the newer information about endometriosis. It depends on where the endometrioma is, because sometimes the endometrioma inhibits the doctors from retrieving eggs, especially if it's kind of in the way of the ovary, because they'll never go through an endometrioma to access the ovary. So if they can access the ovary without going into the endometrioma, sometimes they'll do that ahead of time. And I think having all of your options laid out for you, in any instance, not just endometriosis, but really in any life choices, it's good to know all of your options. And so I am very open to, you know, having them talk with a reproductive doctor and see if that's something they want to pursue, if they want to pursue it afterwards. You know, removing when the endometrioma is there, it may decrease their ovarian quality. Now, not the number of eggs that they're going to make, but it may decrease the quality of eggs that they're making, because it's just this chronic inflammation in the way, and it's kind of bathing in this chronic fluid, which may decrease their egg quality. Now, it may. I just want to remind everyone that you can still get pregnant even with endometriosis without surgery. I do have patients that decide to just do the IVF route. They avoid surgery, and they are able to get pregnant too. We know that excision surgery does improve fertility rates, both with natural conception and with IVF, but it doesn't mean that that's the route that you have to take. I think everybody should, you know, really know your body. Most of you endo warriors have advocated for yourself to get here. You've had to do your own research and learned and you know, educated yourself on all of these areas. So trust your instincts. If you say, you know, this is the way that I want to go, or I want to, you know, have surgery first, or I want to go talk to the fertility doctor first and know my options, or maybe an egg retrieval first, or, you know, trust your instincts, because most of the time you're right when it comes to these things.
Yeah, I think that's really important to talk about too, just like, because not even just like your instincts, but just you still can get pregnant even with endo. Just because a lot of people who have been told that they have endo in general, like read things or hear things or things even from physicians, and they think that they can't get pregnant. And for some people, then, you know, they're not taking protective measures necessarily to not get pregnant. Let's say they don't want to get pregnant now, and they end up pregnant, and they're like, well, I was told I can never get pregnant. Like, that's
it goes both ways.
Exactly.
And, you know, remember, endometriosis is 1 in 10 women. It's probably much more common than that. And so a lot of women just think that their painful periods or the pain that they're having is pretty common. They don't even know they have endometriosis, because this is normal for them. Their mom had this, their grandma had this, their sisters have this. This is the norm for them. Or maybe they really don't have very many symptoms. That's why endo is so difficult, because it doesn't fit in this perfect little box. Some women have, you know, symptoms right from the start. Other people don't start till it's later. Some people have bowel and bladder symptoms. Other people, you know, really are almost asymptomatic except for maybe fertility. And so, yeah, just trusting, knowing that pregnancy can happen. But also, I'm going sidetracked again. Age-old myth of getting pregnant will fix your endometriosis is also not true. And we can go over that in a little bit, but that is one of the most frustrating things that I hear patients tell me that they've heard from other providers. That's just so disheartening, because it's taking advantage of their emotions a little bit, but also, as we know, pregnancy certainly does not cure endometriosis, and some women don't even, you know, feel any improvement in their symptoms during pregnancy. And then once you're pregnant, after you deliver, you know, your pregnancy and your progesterone goes back down, you're going to be back to where you were before. And so
And you have a baby to take care of.
Yes, exactly. And then your body's not optimized for that.
Yeah.
And so it's a whirlwind for sure.
Yeah,
But
and
I
I think
just,
that like goes along. I'm sorry, Liz, go ahead.
no, go ahead.
I was gonna say, I just think that goes along with something you said in the very beginning, that like we're not here just to make babies either. So like, what if I don't want to have kids and you're telling me the only way to fix this is to get pregnant?
Right.
100%. Yes.
Right.
Yes. That is so frustrating. And I see young women all the time that, really don't want to get pregnant. They're old enough to make that decision on their own and, trust women, trust their autonomy. But endometriosis is so difficult because women in general are less likely to be listened to, in a provider's office, but especially young women. And this is the young women that are being mostly affected with endometriosis, at least at first. And so it's kind of a battle to get there sometimes.
Right. I know the girls here know my story, but I actually found the doctor who did my hysterectomy because I was at my wit's ends. I was 29, I was 28, about to be 29 years old. And I found him on Reddit out of all places. I went on Reddit
Yeah.
and I just looked up doctors who are willing to sterilize women before they have children. I didn't have kids. I didn't want kids. And from, when I started suspecting that something was really wrong around 18, 19, I was in college. I wasn't married. Like
Yeah.
I was not ready to have a baby. And doctors were like, well, you have to have 2 kids. And I'm like, well, do you want me to just go like pop 2 kids out real quick and come back so you'll take care of what's going
Yeah.
on? I wasn't surviving. It was hard.
Yeah.
And so when I saw this doctor here in Fort Worth and I went to his office and I said, look, I don't have kids, but I feel like I'm old enough to make that decision. Are you willing to take action? Like, I can't continue to live this way. And he was like, yeah, of course. Like, go home, talk to your husband, come back, let me know what you decided, and we'll kind of go forward. But that's not the norm for people.
Yeah. Yeah. It's really nice that you found that. But I've had similar situations with a lot of my patients, just not being able to find options or feeling like if they don't have a certain amount of children or they haven't met a certain threshold. I mean,
Yeah.
there's also like, they're not necessarily lies, but they're, you hear about these things like, oh, you have to be 30 to get sterilized, or you have to be 25 to get your tubes tied. That's actually not true. That's not true at all. There's not laws in Texas that say you have to be a certain age to get these things done. Now, I think it's reasonable to understand all of the risks and the finality of it, but it really is a barrier to women's care, this aspect, which is very frustrating.
Yeah. So back to what you were saying a minute ago about how, sometimes you recommend for women to get their eggs frozen. So what does that timeline lead up for somebody who would come to your office? Do you recommend them to start pelvic floor therapy before surgery? Do you recommend a second opinion? Like, what does that look like for your patients?
Yeah. So if you want to meet with a fertility doctor and you decide to go forward with freezing your eggs, it's actually a very quick process. You can do it in 3 or 4 weeks. So it's not something that's really dragged out. I'm not saying you have to, but if you wanted to expedite that process, you can do it actually very quickly. I love pelvic floor physical therapy. I think it is important in all aspects of our lives, not just in pelvic pain, but especially when it comes to pelvic pain, and before surgery. So on the first visit, I talk to them about pelvic floor physical therapy, and I try to talk to them about it as in depth as I can. I won't pretend to be as knowledgeable as some of the really good pelvic floor physical therapists that we work with, but just talking about, to them about this is treating you holistically. When you get this multidisciplinary approach is when you're going to have your best outcomes. They are looking at you from a different perspective. I'm looking at you surgically, like where is your endometriosis? What nerves is it on? Like what areas are deep? How can I find this disease to remove the underlying etiology? Physical therapists are looking at you from a very different perspective. And we call it kind of prehab, but trying to get in early. In a perfect world, my patients would work with PT for 6 to 8 weeks before surgery. And I always tell them, when they come into my office, I'm like, if you talk to the scheduler and for whatever reason surgery isn't for you, or you decide to wait, still do physical therapy. Like, please start, treating yourself, kind of working on reversing some of this long-term damage, with your muscles, with your pelvic floor, with your hips, with even breathing, relaxation techniques. And I know I'm missing a lot of very important things. I wish I wish somebody was here to help correct me, but just working with them, getting to know your body more, areas that you usually don't even think of, but the tension and the dysfunction of the pelvic floor can really see a benefit both before and after surgery.
I love that.
Yeah, I
We're
think that's
big
one
components
thing.
of that.
Yeah, I think that's one thing that's like really important too. Just because when a lot of patients that have endo, you know, because it is this like chronic inflammatory disorder, like that doesn't just wreak havoc on your uterus or on your bowel or on
Right.
your bladder. Like it's kind of widespread. And when you're in this like chronic pain, a lot of times you're chronically guarding everywhere too. And guarding with those muscles in your pelvis, and then they end up
Yeah.
being overactive and tight and spasmy. So like
Yes.
that's one other thing that I feel like I've learned is that like, you know, you can have a really, really good excision surgery and you get everything. And then sometimes patients are still in pain, even though you've
Yep.
gotten rid of the underlying like etiology, or part of it, I guess, like the one of the causes. How do you usually like handle that? If a patient comes back and they're like, okay, thanks so much, you did my surgery, you're awesome, but I'm still having all the same symptoms.
Yeah.
Or does that happen often?
Yeah. No, I mean, I like to think I'm good at what I do and I love what I do, but I am not the fix all. You know, I remove the underlying etiology, I remove the problem, the cells, this inflammatory response. But we think you probably had these cells since you were born. I mean, these implants that start growing, you know, when we reach maturity, sometimes fast, sometimes slow, they cause chronic damage to nerves, damage to muscles, damage to, you know, the central sensitization of pain. And so it takes time to reverse some of these, you know, symptoms that you're having. So I try to talk about it before surgery, not just after surgery when all of their problems aren't fixed, but help them with anticipation of kind of what next steps are. You know, hey, after surgery, once you heal, once you get to that 6-8 week mark, if not everything is perfect, that's okay, because hopefully you're going to start to see more benefit than you did before with physical therapy, you know, with other modalities, maybe, you know, medications to help with nerve pain, or, you know, help you relax some of your muscles, or, you know, whatever next steps are. We try to focus in on those organ systems and kind of how we can work with those, you know, to get the most out of surgery. Usually I ask patients, this is, you know, as I've had a little bit more experience, I've started to see a trend. Really, this first year after surgery, the time you put in is the commitment is when you're going to see the most benefit, like this first year out. So I really try to encourage them to be pretty, you know, proactive with their pelvic floor physical therapy, really working towards whatever next steps are, or what, you know, symptoms, organ systems maybe need a little bit of help afterwards.
Yeah, that's awesome. And I feel like one thing, even like for me personally as like a patient, even though I knew all the pelvic floor physical therapists and knew all the benefits and all the things, like I still, even though I was in chronic pelvic pain, I had endo, I still didn't even like myself go to pelvic floor physical therapy until,
Really?
well, I did once you were like, okay, well, you need to get in at least a couple of times before surgery. And I was like,
Yeah,
okay, fine, I'll go.
I know.
And I went and it was so helpful, like even just for things like, okay, let's figure out how you're going to move after surgery when you're not wanting to like contract
Yep.
your ab muscles because it's going to be painful. And I was like, I didn't think of any of these things. So glad I came at least times before surgery.
They always say people, even though like providers, people in the medical field, but really anybody that's well educated on disease, even if you know what to do, sometimes it's hard to take that next step to actually practice what you preach. I mean, I am guilty about that, like healthy eating, exercise. I fall off the wagon all the time, but I try to get back on. But yeah, I'm right there with you. Just
I also think a part of it is like who you're going to. The PT or the therapist I was going to post surgery, just did a lot of like massaging around my
mhm.
and so I was like, I don't feel like this is helping. So I stopped
Yeah.
eating and my pain started coming back pretty strong. My OB-GYN
Mhm.
was like, I think you should go back. And I met with a new physical therapist who does all the works. And
Yeah.
felt such a difference since
Mhm.
seeing her. And it's a difference I didn't see with my previous therapist. So it was kind of like I wouldn't like to shop around in my
Yeah.
therapist, but sometimes it's what you need to do.
Yeah, I think that's really good advice. And you were absolutely right. There are physical therapists that are just have more skill set. You know, they have more experience, more skill set, kind of know how to manage this endo, rather post-surgery, pre-surgery, this, you know, just the pelvic floor in general, just more tools. And sometimes that's even hard as me as a provider, knowing who to send people to, because just because they say pelvic floor physical therapist, they're not all as well versed in some of the techniques and um, you know, have as much experience.
Sure. It's very true. I think it's that way with any provider we see. I mean,
Yeah.
we see that in the endo world where a bunch of people are going to doctors who are very used to delivering babies all day long, and that's their focus, and that's where they spend their continuing ed and their training. And we're not seeing the same outcomes as we do when we go to an excision specialist. And that's a really important thing for us that we push to our community is, hey, you have to make sure that the doctor you're going to is familiar with it and can identify it, because there's nothing worse than our community members going and saying, I spent $5,000 on a surgery. They opened me up and they found nothing. And then 6 months later, they have to pay for the same surgery again. And that's
Yeah.
really hard. Having endo's expensive.
It is so expensive. And really knowing people that know what endo looks like. I mean, all I do is endo, right? I do surgery 99% of the time is for endometriosis. And I am still sometimes surprised at what specimens come back as endometriosis. A lot of times I know I'm like, this is pretty, this is pretty classic endometriosis. Other times I'm like, this tissue just looks a little bit abnormal. I'm not sure if it's going to come back as endometriosis, but I told her that I would remove everything that looks abnormal, and it comes back as endo.
Wow.
And so sometimes I don't even know, but it is frustrating. I saw a young patient this week in my office, and she brought surgical pictures. Sometimes I can tell with surgical pictures, and her doctor told her she did excision, which is true, but she didn't remove all of the abnormal tissue. She just removed like a fourth of it, maybe.
Oh,
And
no.
so it was excision technically, but it wasn't removing all of the disease. It was just the areas that maybe she felt comfortable with, which is fine. But it's very frustrating for me because I'm like, you just had surgery. I don't want to take you back to surgery right away. But you can see on the pictures, and sometimes you can't, but it was pretty obvious that it was still there in a lot of areas. And even though she technically had excision, it was an excision of all the abnormal tissue areas. And so it's I mean, I can't say for sure, but it's very likely that it's still there.
Yeah, that's pretty similar to my experience with you.
Yeah.
I had ablation with my OB-GYN in April of the year. And when I went 5 months later to you with my surgery pictures, you started just kind of circling all these spots and
Yeah.
saying these are all parts that got missed. And I remember I was sobbing my eyes out. But you were just like, if you want to do surgery again, I'm more than happy to. And I
Yeah.
think that's also like a big part. Like I was not sure if I wanted to go back and have
Yeah.
surgery so soon.
Yeah. I don't blame you. It's very difficult, physically, emotionally, financially, and it is heartbreaking when you just had surgery and you just recovered and you trust your doctor. And these doctors are not bad doctors.
Yeah.
You only know what you know.
Sure.
And we are not trained well in residency to know about endometriosis. We are not given enough time. In OB residency, we are focused on baby making and delivering babies. And that's also very important. And it's difficult. That's very, high stress. These patients, change dramatically. It's important to know that aspect too. But women's health is so much more than just obstetrics. And it's really a disservice how much time is given to women's health issues outside of pregnancy, in residency and in our training, both in med school and in, fellowship or residency.
There was some information that we had seen early on when we started the nonprofit that it was estimated to be about an hour that y'all get an endometriosis training. And when we pass this information on to our community, people's jaws literally hit the ground and they're like, are you serious? And I'm, yeah,
Yeah.
that's the estimated amount. People
Yeah.
can't believe that.
it's probably right. I mean, in medical school, we have, I mean, everyone's a little bit different. You have like a 6 or 8 week, short time to learn about OB and GYN. And most of that is spent on pregnancy. A lot of it has to do with like hormones, menopause, contraceptives, and then just like a tiny little bit about pelvic pain. Bloop, and then endo probably has like one blurb. It's just,
Oh, no.
I mean, it's just insane. I was lucky in residency that I worked with some MIG surgeons and Dr. Michael Hibner. He does a lot of pelvic pain up in Arizona. And so I was lucky that he was in residency with me. So I did get more experience certainly than most, but then he sort of guided me to fellowship too, where like 70-80% of what we did was endo, but my experience is not common. It's usually much, much less experience with pelvic pain in general, but especially endometriosis.
Sure.
Yeah. And
Along the lines of like having multiple surgeries, if a patient suspects that they have endo and maybe they can't afford right now to have excision surgery, maybe they know they can in like 3 years, but they're symptomatic, would you, I guess this is like personal opinion, obviously.
yes, yes.
Would you suggest that like they just go to their general OBGYN and have like an ablation, or wait if they can wait for 3 years to get an excision? Is there risk benefit, I guess, of like having an ablation and then an excision, or like just wait for the excision?
That's a tough one, Janelle. You're putting me on the spot.
I know, sorry.
I have a motto: do it once and do it right. Make sure that we don't miss anything. Make sure that we look everywhere in the abdomen and pelvis, and that your surgeon feels comfortable managing whatever they find, whether it's on the diaphragm, the bowel, the bladder, around the rectum. Just be very thorough, get it done correctly the first time. We're starting to see some evidence that women that have ablation may have less benefit from excision, the next time, because just the scar tissue and kind of the damage from the burning. I think if I have a patient that comes to me and only had ablation, maybe even if they've had 2 or 3 surgeries, they should have a good excision surgery at some point, because that is where they're going to get the most benefit, long term, less risk that it recurs, better chance that we've removed all of the cells and tried to get like the macroscopic disease with wide margins. But surgery is expensive. If people can't pay for surgery, that is fine. I will work with them on other options, get into physical therapy. This is a personal opinion, and I don't push medications on anyone, because everything we put in our body has side effects, right? Good and bad. But, if they have no other option and medication has worked for them in the past, maybe that's something they could consider. Again, I certainly don't push it. I feel very strongly in women's autonomy. If you don't want medication, I'm not going to make you do it. Like, you don't have to fail all of these medical options before you can have surgery with me. I think that's insane. But that's also something else to at least discuss maybe progesterone only options, or, something in the past. Just putting everything out on the table so that the patients can make, the best decisions for themselves. Medications, like especially hormone suppression. I heard another endosurgeon explain it this way, and I think I agree with how they explain it. Medications help treat the endometriosis symptoms, but they don't treat the endometriosis itself. And I think that is a reasonable way to explain it. And sometimes it doesn't help. Sometimes it doesn't help the symptoms at all. Sometimes it makes them worse. You get worse side effects. But I think it's at least, if a patient can't have surgery for whatever reason, I think it's at least worth some sort of a free discussion that's not intimidating, because nobody should feel intimidated to have to try something that they don't feel comfortable with, but at least, letting somebody know their options.
Love that. Sorry, that was like a kind of super.
Yes, you put me on the spot.
And just so our community is aware, because a lot of people are pretty new with terminology. When you say hormone suppression, are you talking about like Orlissa and those types of medications, or what are you discussing there?
I usually give all options. So progesterone only options with like progesterone pills, Slind, because they can be very uncomfortable. If I do it, I only offer it, during surgery. One, I just don't really have the tools. Two, it can be really painful to put in, and women with chronic pain don't need that additional, insult. So I'm kind of talking about all of them. So progesterone, estrogen and progesterone combined pills. I rarely prescribe, Orlissa, Lupron, not because it doesn't work for some women, because some women it does. It's helps them, it gets them through college. There are side effects of them, and unfortunately, you can't be on them long term because of some of the effects on your bones. The FDA has only approved it for a year, sometimes 2 years, and so it's really it's a band-aid. If patients come to me on these medications and they're working for them, I don't take them off. If it's working, you just keep going, and we can, still treat you, still have surgery while you're on these medications. There's also some, I've heard from patients, well, my doctor wanted me to come off the Orlissa or the Lupron to have surgery so they could see my disease. I'm like, no. You do not, if it's working for you and you don't have to come off of it and go back in pain, just to plan for surgery. That is someone that doesn't have as much experience. So I guess when I'm talking about suppression meds, I'm kind of talking about the gamut, not necessarily just the ones that are like menopausal inducing.
Yeah. And so I myself am in surgical menopause at, I'm going to disclose my age, 33. And it has been a really challenging year because I have to be on hormone replacement. I lost my brain after surgery because I did not have hormone. And now that I am on hormone replacement therapy, I'm starting to have pain again. So a lot of our community is in this boat, right? Where they've had their ovaries out or their ovaries have failed after they've had one out. What is your approach to that? Where we're juggling this ball of and putting more estrogen back in our body.
I know it is so hard. And you're not alone. I mean, this. You're the queen of advocacy and kind of knowing the history, but this happens a lot. There's not good evidence that estrogen replacement causes endometriosis to return faster, because there may be some aromatase properties of the endometriosis itself. So it may actually be making its own estrogen to some degree. And so then you have to just, weigh the risks and benefits. I typically still recommend estrogen replacement until the average age of menopause, which is 52, for the bone protection, cardiac protection, cognitive protection. But I also understand everything we do is, risk and benefits. And you certainly, when you see that pain, creeping back in, it's petrifying, because you've gone this far, you've made these big strides, and even if it's just a twinge, it reminds you of kind of how it was before. And
Trauma.
so it is, yeah, for sure. And it is PTSD. I mean, it absolutely is, because it affects you physically and emotionally. And so it's a tough place. So, I mean, I usually just kind of give this counseling, talking about risks and benefits, and then we decide together. If you come off of the estrogen, cold turkey, and your pain gets better, and you have the menopausal side effects, then you kind of have to decide, next steps, or maybe try a different form of estrogen, like with a patch or a cream. But usually, the creams aren't enough for young women, because women, especially younger women, need a much higher dose of estrogen to meet their like natural requirements.
Sure.
So that's not a perfect answer.
Everything about endo is never a perfect answer.
Yeah, it's tough. It's really tough. Yes, a lot of trial and error, and everybody is different. It would be so nice if there was just, a spreadsheet we could put out for women with endo. So, try this first, next steps, try this, do this next steps. If this doesn't work, do this. But everybody is so different, and everybody's symptoms are different. And so it is just a difficult, it's difficult to traverse this for each patient because it's so individualized.
Oh yeah, I feel like you can ask like 50 people about one hormonal birth control and you'll get 50 different answers.
Oh yeah.
Good or not,
yeah.
side effects.
I mean, Google any of these medications, or really anything, and you're going to get conflicting answers on both sides. And a lot of times, especially when it comes to medications, you get really strong opinions on both sides, whether it's estrogen, hormone replacement, birth control pills, surgery. you name it. You can find somebody that's on your side or that's like very strongly against you.
So one thing you were talking about earlier is if a patient has adenomyosis, of course, like the uterus being removed is the only treatment, right? But how do we, before surgery, how do we identify if that's the case? Because, here, any research that I've ever done and anything I've ever heard is endo doesn't show up on imaging. So does adenomyosis, like what is that? What is that, those steps that people should take?
Yeah, that's a great question. So endometriosis and adenomyosis overlap in a lot of their symptoms. And so sometimes it's hard to differentiate what is adenomyosis, what is endometriosis. So first, I'm going to go through like classic adenomyosis symptoms. This is not hard and fast, just like endometriosis. Does not mean that it's perfect for everybody, but typically with adenomyosis, you have heavy periods, prolonged bleeding more than 5 to 7 days, and pain with your period. So you see that overlap really fast. You're like, well, that's endo. But those are the symptoms of adeno that you kind of pull out. Sometimes, especially if the adenomyosis is a little bit more extensive, you can see this on imaging. So what you're looking for on ultrasound is what they call a heterogeneous appearance, or if the tissue has like little lakes of fluid in it, that may be more indicative of adenomyosis. Same thing on the MRI. They actually do some measurements for the thickness of this muscle. And there's, again, conflicting diagnostic criteria, but anywhere from 6 to 8 millimeters, if it's over 6 to 8 millimeters, that may be diagnostic of adenomyosis. With that being said, I have women who we both, patient and I, have a high suspicion they have adenomyosis, want to preserve their fertility. We go in, we remove the endometriosis really aggressively, and they still get a benefit knowing they have adenomyosis, or likely have adenomyosis, because technically it's a diagnosis of pathology similar to endometriosis. But, when I look at it, during surgery, it looks like adenomyosis, they have symptoms consistent and they still see the benefit. So just because this is something on your differential doesn't necessarily mean you have to move towards hysterectomy. But I do counsel them that there's a chance that if you still have pain, that it may be the uterus itself causing some of these symptoms. And usually during surgery, the way that it looks is the uterus should be kind of hard, like the back of your hand, like just a muscle. But during surgery, if it has adenomyosis, if it's extensive, it's kind of like a sponge. So I use my tools to push it in, and it takes a while to pop back out, truly like a sponge. It just looks boggy. Or for the pictures, it's not smooth in color. So a uterus should be like a pinkish purple color that's smooth throughout. With adenomyosis, it's mottled, which means there's like colors that are lighter that almost look like almost white. There's darker purple and lighter pink. So the uterus color is not smooth. And so those are at least signs that there's likely adenomyosis, or at least some adenomyosis there.
That's so interesting.
Yeah, it is, but it's very difficult. So, to kind of tease that out. Women with endometriosis, 30% of them have adenomyosis. And so it's actually a very common disease to have together.
Mm-hmm. Wow.
So if a patient, we know we have adenomyosis and are wanting to potentially have a kid maybe in the future, what is, and I don't know if you know this or if this is something anyone knows, but like, does adenomyosis cause issues with fertility? So like we're leaving the uterus to preserve fertility, but then does that cause issues with being able to carry a pregnancy?
It can. Usually it's just with implantation. Once the pregnancy gets going, it doesn't increase your risk of, early delivery or miscarriage after the first trimester. It's usually the act of getting pregnant. It can make it a little bit more difficult. And to what degree, we honestly don't know. And I've talked to my fertility doctors. I'm like, hey, give me some stats here. Like, help me help you. Like, when patients ask me, they want to know, how much is this going to affect them going forward? Like, how many women with adenomyosis are able to get pregnant? Like, is there a degree of adenomyosis that makes it harder? Nobody knows. But it does make getting pregnant a little bit more difficult. Truly, that's what we know. both with IVF and with natural conception. And so you can't really circumvent that with IVF. And so it has to do with kind of the implantation and just the healthiness of the blood supply to the endometrium and the inflammation. Really, it's the inflammation that's kind of caused, and that's what we think makes it more difficult.
That makes sense.
I think something we can all agree on is we have a long way to go.
Oh, don't we?
Yeah.
Yes. I mean, it would be so nice if we had, other ways to treat endometriosis besides surgery or putting people into menopause medically or, or removing all of their organs. I mean, it just, we have so much to learn. And, there's some genes that are being studied and kind of targeted to see if we can, treat endometriosis certain ways. And there's some genetic testing that's coming along to try to see if we can kind of pinpoint where these genes are coming from. And we're just not there. And there's some things in the pipeline that may be promising, but also when you look at the papers and the studies, like, yes, we found the genes for endometriosis, but there's like 27 of them, not just, one that we can pinpoint, just 27 that tend to be a trend. And so it's, we certainly have a long way to go.
That's crazy. Wow.
Yeah.
Definitely. Like not just even like in treatment, but like diagnosis itself. Like, because I feel like that's one of the issues with treatment almost is like not being able to even get a diagnosis when the diagnosis is basically treatment.
It is.
Except for when you're getting like diagnostic laparoscopy.
Right. Well, it's such a barrier to women's care. I mean, to have surgery to technically get a diagnosis is just insane. But that's the best we have. Imaging misses it 90 to 95% of the time, unless you have an endometrioma. Because cysts we can see well, on ultrasounds and even MRIs, but endometriosis in general. I mean, I'm preaching to the choir here, but most of the time is missed. And it's also infuriating when these young women have had all of these normal exams. And so, normal imaging exams. And so then they just feel devalued. They feel like their symptoms aren't real. Well, I keep having normal tests. Well, it shouldn't say normal. They should just say what they see. The uterus is this size, the ovary is this size. Doesn't mean it's normal. It just means what you can measure, what you can look at is, within the range, but it certainly doesn't mean that there's nothing else going on. You just can't see it.
Right. And I think this is something we talked about on a podcast previously, but we don't, as women, really know what normal is. Like, what should a normal period feel like? It's not.
What are normal cramps?
Yeah. What are normal? Like, are you supposed to cramp during a period? How many days are you supposed to bleed? Like, we don't know any of this. And so when you're trying to advocate for yourself, it's really hard to say like, no, I know for a fact this isn't normal.
Right.
You can throw a rock and probably hit the next person who has very similar identical symptoms as you. So we don't ever know.
Yeah, it's true. I usually use this analogy, your friend called you, they're like, oh, I started my period this morning. I took some Advil, I went for a run, I'm going to work. Do you want to go have dinner later? And you're like, wait, what? I thought you just said you started your period, like, but you've done all these things. That's actually normal. You're like, hey, I was a little bit irritated, but I was still able to exercise. I went to my full day at work and I feel like I have enough energy that, I'd want to go have a drink after work or go have dinner or be social. It's not affecting her quality of life. She's still able to function. She's still able to be social. Like it's a nuisance, but it's certainly not something that is debilitating. Bleeding more than 7 days for your period is abnormal. They talk about an actual, we know milliliters or cc's of blood that you're allowed to, that you should be bleeding for it to be normal, but nobody knows that because you're just wearing tampons and pads. Nobody's truly measuring it. But soaking through pads throughout the day, needing to wear super plus tampons and, a pad when you go to work is certainly not normal. Bleeding through your clothes is not normal. But just, really for us, especially in the endo world, is the pain aspect. Just how it affects our daily functioning, how it affects our lives, physically, mentally. You anticipate this terrible, insult coming with your period, the few days before. you know, your period actually comes, it's also debilitating. And then afterwards, some women are starting to have, you know, pain with ovulation. It kind of just creeps in. You know, it starts with just few days a month, and then before you know it, it's half the month. And then before you know it, you only have one good week out of the whole month. And that's terrible.
Yeah.
One thing that one of the things you said made me think of is just like, you know, when you're talking like heavy bleeding or you have pain during certain times. I think one thing that's important too is like you don't have to have every single symptom in order to have endo. Because like even myself, like I knew I had endo. I'd had endo for years. Like I was one of the like lucky people, I guess, that like I had an OBGYN mention it to me at least.
Yeah.
Did anything about it. Told me to wait until it's so bad that I can't live basically before we operate, which kind of on one hand glad that we did that because she would have just gone in and done a bunch of ablations. But like even when I was seeing Dr. Haverland, knowing that I have endo, I was even talking myself out of it. Like she was like, yep, sounds like endo, let's do surgery. I mean, it wasn't that simple, obviously, but and I was like, yeah, but I don't really get like bloated like a lot of people do. And like my
Yeah.
periods are kind of heavy, but I feel like they're normal. Like they're not that heavy all the time.
Yeah.
And like I was like, maybe I don't. And I still, even like knowing everything that I know, like was like, all right, we're going into surgery, but she's gonna come out and tell me she didn't find anything. Like I know it's gonna happen.
Yeah.
For no reason though. Like I was like gaslighting myself almost.
Mhm.
Yeah.
And I feel like part of it also, like when my symptoms started, like, and I'd go to an OB-GYN, one of the first like 10 questions was, how heavy is your flow? And I've always had a very light one. And I think I've mentioned this to Liz before, but I feel like that was part of my diagnosis being so much later in my life. If I would have said from the beginning, like, it's heavy, it's long, it's, you know, like those kind of what you usually hear. And me saying like it was light, I feel like that made me get dismissed for even longer.
Yeah. You're like, why did I not just tell them buzzwords that they wanted?
Right.
Like, give me my diagnosis.
But I feel like there are people that have all of those symptoms and have all of the things and still don't get a diagnosis. So
I was waiting for 60 days at one point, and
Oh my
still took me
gosh.
14 years. I was told that was normal.
Yeah, that is terrible. And this self-doubt is so real.
Yeah.
I mean, I have women that have path positive endometriosis. You know, maybe their doctor went in, was like, I'm not going to do surgery. I just told them I look, and they still have self-doubt. I mean, I think there's a lot of factors that go into this. One, because maybe they've been told for so long it's not real, you know, multiple normal imaging. And just, I try to tell women, trust your instincts, trust yourself, believe women. Your symptoms are not normal. But everybody asks me this, you know, pre-op surgery, even right before they're going to go back to surgery. What's going to happen if you don't find anything? And everybody asks me that. That's their biggest concern. I talked to them about the risks of surgery, bleeding, infection, you know, dying. Not that that happens, but they don't care about that. They're like, well, what if you don't find anything? What if everything that I've been going through is not real? And it's really disheartening. But I try to just reassure them, you know, the symptoms are real, that these symptoms, you know, are not normal, that you meet these criteria, and just reassure them. But it's so difficult. And I think that's where these endo communities are really helpful, is because you do give each other support. You remind each other that they're not alone. You know, they you know, validate, you know, what they're feeling.
Mhm. It's almost like we have something to prove to our family and friends who have been on this
Yes.
journey with us for so long,
Yeah.
that you weren't making it up, that you weren't exaggerating. I mean, unfortunately for us in the endo community, we want something to be wrong, which is so
Yeah.
backwards from how you typically want that to be. But we so eagerly want to go into surgery, and for you to come out and say like, you had stage 2, stage 3 endo, like
Yeah.
we're excited for that. And that just should not be the case. That has to change.
Yeah, I agree. And I think you're absolutely right. Proving to someone else, it's not really proving it to yourself, because deep down you already know.
Yeah.
But being able to prove it to other people that this was not just made up. And we all know that here because we're in a safe space, but out in the real world, out of the, in the community, it's not always the case.
Yeah.
Yeah, and I think it especially stems from being told over and over again, like, yeah, your scans are normal. There's nothing wrong with you. Like,
Right.
welcome to being a woman. Periods suck for everyone. You just can't handle it. Like,
Yeah.
Yep.
Yep.
Well, I think that's, oh, go ahead.
Sorry.
There you go.
We keep mentioning the words pathology and like your scans are normal. I see a lot of back and forth between women that say like, oh, I had an endometrioma show up on my scan and I was diagnosed with endometriosis. And then there's the other hand that say that diagnose it, like you're not diagnosed until you have surgery.
Mm.
What would be your take on
Yeah.
this?
So there's a few things that we can see with imaging. One is ovarian cysts, especially with ultrasounds. Ultrasounds are better at looking at ovarian cysts. Sometimes they're wrong though. No matter how good we are, we're still not perfect. So same thing with ultrasound imaging. Sometimes they can identify endometriomas, and a lot of times they're right. They can, however, look like hemorrhagic cysts. So instead of being filled with chocolate fluid, they're filled with blood, and sometimes they look very similar. But I try not to lean too much into like do you technically have your diagnosis? Because almost woman that walks into my office, I'm like, yes, like this is likely your diagnosis, technically not. So I still stick technically with pathology, but if they have these diseases, or these findings, I just try to reassure them that, this is kind of just fitting into this box. But if they've been told they have endometriosis, I just believe women. Just believe them when they tell me what's going on. It just sounds just a crazy idea.
I wonder if women who have had like their diagnosis through like an image are choosing not to go into surgery because they already have their diagnosis in a way. And I mean, personally, I would still want to have surgery, just for my peace of mind and to get it cleared out if possible. But that's just, I wanted to pick your brain at that.
Yeah. Endometriomas, if they truly are endometriomas or an endometriosis cyst, they rarely reabsorb on their own. That fluid in there is so thick and it looks like chocolate, but it's just really thick. It's very difficult for your body to break that down and reabsorb. And so usually women with cysts at some point will need to have surgery just because those cysts continue to grow rather slowly or quickly. And then at that point, usually they have to, but it is a personal decision. And I think you can, again, just trust your instincts on kind of how you feel, what's the best next steps or timing.
Yeah.
do you ever see where like endometriomas rupture?
It can happen. So when I first started, I was like, this never happens, but it does happen. Because I was taught in training that it didn't happen, but it does. It's less common. Usually they're more hemorrhagic cysts. But I have seen endometriomas rupture. I've seen it firsthand, in surgery. The whole pelvis looks like, a little chocolate fountain. And so it certainly happens. It's less common, but it certainly happens.
The only reason I ask is like I hear from some patients sometimes that like, when they're in a ton of pain and they're going to the ER and then, maybe they do an ultrasound, they're like, oh, you just had a cyst that ruptured. And then they're told like, well, it happens, go home, see you later. And then, years later, maybe it's happened a few times. And then years later, they end up diagnosed with endo. Like, what were those rupturing cysts, like endometriomas, or were they hemorrhagic cysts?
Yeah.
I don't know because I'm there or anything, but
yeah, it is hard to know. With endometriosis, when you do have cysts, even if they're not technically endometriomas, your body just may be more sensitive to them because it's just hypersensitive, more angry, more inflamed. So a cyst that most people wouldn't be a big deal, like just ovulation or your cyst coming, it may be related to endometriosis, even if it's not an actual endometrioma. Yes.
Yeah.
The fact that you're saying that, because I've had people who are like, oh yeah, because I also have a history of ovarian cyst rupturing. Like, oh, I've had one rupture too. And I was like, why are you saying it so nonchalantly? Like that takes me out for 2 weeks.
Yep.
And for you, it seems like it's just a walk in
Like,
the park.
yeah, a pain for like a minute. You're like, oh, that hurt. I was like, oh, that'd be nice.
Yeah, it makes sense that because everything's like irritated and whatnot, it'd be more.
Yeah. Yeah, and the damage from the nerves just from having endometriosis for so long. I mean, rarely is a person diagnosed like, when they're in their young, early teens, because it's probably been there. That's when it starts growing. And so your nerves and your body has damage, just from this inflammation from being there so long. So it's kind of multifactorial there.
Well, I think that's a good place for us to end. We really appreciate you joining us, Dr.
Yeah.
Haverland. This has been awesome. This is such good information that our community can definitely take and advocate for themselves. That's what we are big proponents of, is advocating for yourself. You know your body better than anybody on the face of the earth, including a doctor.
I
Advocate.
agree.
So yeah.
Yeah. No, Liz, thank you for having me. Thank you, Ritza. It's so good to see you guys. I'm glad you're doing well. And yeah, thank you for having me. This is such an important month, and it's so important to advocate for yourselves and for these other women, because the more that we get it out there, ultimately my goal is by the end of my career is to treat women earlier, give people more access, and we're doing it slowly but surely. But I think the more we talk about it, the more we bring it to the forefront, the better it'll be for everyone.
I agree.
Definitely.
Yep. Well, if you haven't had a chance to check out our website, please head on over to endoforwardfoundation.com. We are going to be hosting an event every weekend in March here in the Dallas-Fort Worth area. An event's coming to Austin very soon, and we can't wait to meet everyone next month. Hope you have a good night.
Thank you.